about him at this point. Good morning, everybody. Thanks for joining in. Just wanted to touch base about a couple of things and just kind of keep us going on our bi-weekly meetings. Bi-weekly? Yeah, bi-weekly is the right word, I think. Yeah, it would really be horrible to talk to you guys twice a week. So I think it is indeed bi-weekly. So anyway, as COVID is kind of rattling its way through, and there's still a high risk of a second wave, I think we're just going to kind of keep holding tight and just kind of doing the things that we're doing. A couple of little nuanced changes that I want to point out today, and then I want to talk a little bit about stuff different from COVID. I want to talk a little bit about refusals. Not that it's been a huge problem lately, but kind of looking to the future over the summer and some of the changes that may come in your EMR. And so I want to bring these things kind of to your attention now. Before we get too much further down the path, I want to start with a COVID update. So one of the updates I want to give is that so far we are still seeing decreases at OSU when it comes to our admission rates and our ICU admissions and things like that. So that's a good thing. However, I did talk to one of my friends down in Alabama who is working at UAB at Birmingham. And what he informed me, because Birmingham's right there between Georgia and Louisiana, where they've actually opened up the floodgates completely. And what they found is that they actually came down for a while, and they're having a pretty significant second wave where they're actually back to the levels they had at their peak. So I think every state is going to be different, and I think every state and their experience of each state is going to be different, but we should, again, prepare ourselves. And now that we're seeing some data that some states are having a second surge and some cities are having a true second surge, let's be prepared and keep our minds focused on what could happen and just be prepared, which I think is one of the big hallmarks of what we've been doing for the last 2 months. We are quite prepared, possibly over-prepared, but we are ready as needed. The second update is airway management. I know we sent our memo on airway management, focused specifically on cardiac arrest and respiratory distress. As the COVID thing is ramping up, one of the things I do want to clarify is we are putting a complete kibosh on combined nasal intubations. So a big part of that is the amount of respiratory stuff that you're going to have coming in your face when you're listening, to make sure that you have good placement. And so again, that's unnecessary aerosolized products going towards you. And with the data of the complications associated with nasal intubation, you guys will be getting a memo directed towards that concept. So those are the two main big updates I have. Other than that, I think we're doing a phenomenal job. Our numbers are a little down, but we are still having the same old chest pain, STEMIs, strokes, things that we normally see are still happening at the rate that we would expect them to. And so definitely hold tight, and let's keep our eyes open about what might come over the hill. Before I move to the next area of discussion, just want to open up for any questions before we move on. And I'm mildly proud of myself that I did the updates in 3 minutes. Excellent, great. So I'm gonna now share my screen if I have permission. Glenn, can I have some permission? Thank you, my friend, appreciate it. Okay, so I'm actually excited about this quick conversation with you guys. We're talking about refusals. Now, refusals are definitely not the sexiest thing in EMS, but sadly, it is a big part of our lives, specifically about the fact that we see so many times per day that we have to do refusals. The scarier part is it is one of the more concerning and one of the more scary things that we have to face when it comes to our care plan. And I think that's one of the things that we have to kind of keep in our mind, that refusals are probably one of the more common things we see. They're utterly boring and painful, yet they are probably one of the more high-risk things that we do. So with that being said, as a team, from the medical director's side, we decided that this would be an important topic for us to actually take a little bit of time and really look at what we're doing so we can think to the future about what we can do to improve refusals, because this is a problem across EMS. Excuse me for a second. There we go. Okay, great. So, of course, our focus has always been the same. We're improving pre-hospital care through a unified system-based approach to comprehensive, innovative care. And what I'm focusing today on is on innovation. and really specifically about the concept that we want to innovate and find better solutions to what we're doing so that we can actually be a little more clear about situations where refusals are appropriate and where refusals shouldn't be appropriate, and actually have a better idea of identifying the patients who are high risk and those who are not, and that way we have a cleaner pattern. So right now we take refusals, and in the literature there's no clear pattern about what's the best way to do this and which ones are safe or not safe, because people are refusing every single day who have high risk and actually do have bad outcomes. And so what I'm presenting is actually data that we presented in January at the NMSP conference. And with COVID and everything, I never had a chance to present this stuff to you, but there is some amazing work done by Shelley Gannon as part of our team, supported by Jeff and a lot of my EMS fellows and residents, to kind of move this to the point that it was a workable product where we can really look at our data. And so I want to give a lot of shout out to Shelley and really talk a little bit and give a little love to our team for putting this together. So what we're talking about is the assessment of EMS documentation for capacity assessments. So one of the things you think of right at the bat is we're assessing EMS documentation. Well, what we're assessing is what is medical legally protected for EMS documentation. So let's put a concept of this, and we'll talk a little bit about that as we go around. So in general, we're in a unique environment where we take refusals every day to go to the medical center. And often these refusals, we have a form, right? We have a capacity, we have an assessment form, and we follow this systematic assessment, and they're not really conducted to that level because we actually have to just have our form done. And the great thing about our form is medical legally, we all kind of use the same form. Every medical director throughout the country, we have the same little check boxes. It's all the same. And it has been tested. And medical legally, it's actually failed a number of times. And then when you start looking at the literature itself, when it comes to assessments of capacity, it becomes a little challenging. Can I zoom my screen out a little bit? I can't. Sorry, Glenn. Is it too big? Here, let me do it this way. I think my screen is a little confusing, so let me see if I can fix it really quick here. And if I can't, I'm going back to the other version, Glenn.
It was fine the way it was.
It was fine the way it was. Thank you. Moving on. Okay. So, so what we did is we did something a little different. We took the literature from the geriatrics population, because we have actually an EM geriatrician, so emergency physician who focused on geriatrics. And she had a lot of experience on grabbing capacity assessments of geriatric patients in the ED so that we can make decisions if we can send these people home or not. Now, notice I'm being very specific. I'm talking about capacity, not competence, right? So when we think about competence, competence is an assessment which is done by the courts, where they really say this person is competent to do their daily living and all that kind of stuff. We don't care about competence. All we talk about is capacity. But in EMS, we don't have a defined concept of what capacity is. We have some general guidelines that we provide ourselves through our form, but there's never really been a study to substantiate the power of that form or to say that this is really a good capacity assessment. So what we did is we leveraged what the critical criteria for capacity is in geriatrics, because we recognize those are the highest risk patients that we would be taking refusals from. And what those characteristics are: the ability to communicate, the ability to recall, the ability to apply appropriate information to themselves. I think we all recognize that patients have challenges with that. We'll tell them, you're going to die if you do this. And they're like, yeah. I'll just go hop on my tractor again, right? And clearly there's a disjoint in the ability to apply that information. And last but not least, understanding risks and benefits is always a challenge. Now, one of the things that we as EMS have a challenge with is our standard of care right now is checkboxes, right? Everyone wants the checkbox in a signature. And what's happened in the courts is that that's actually proven to be not the best defense, right? And so in the courts, what they've shown, and this has happened a number of times, is even if you do your checkbox and somebody signs off, if we actually have a bad refusal that we missed, we can still be held liable. And so though all of EMS has gone in that direction, we need to further look at this question and make sure that we're doing the right thing and we're moving in the right direction. And so that's where all this came from. So our objective was to describe EMS documentation and capacity assessments during patient refusal. So we conducted a one-year evaluation of all our face-to-face interactions, which led to refusals. Okay, and so when we selected a subgroup of 50 randomly selected refusals, which we went through a detailed review by two abstractors. So two of our people went through and pulled these charts and reviewed these charts and defined those 4 key characteristics in the charts. And then we just evaluated for the data. So here's the interesting stuff. So the first thing, well, of course, we had about 4,000 calls that year in 2018 with 492 refusals. So 15% were identified as pure refusals. And we did do some exclusions, so that's why the number seems a little lower than you'd probably think. So when we look specifically at this table, you're going to see that the vast majority of our refusals were in the general adult population, anyway from 18 to 64. But if you break down that 18 to 64, it's more like 60 plus is our larger, actually 55 plus is almost 50% of our refusals. So, but the very fact that we have geriatrics greater than 65, that 33% are taking those refusals, it's a little challenging. So the subgroup of 50 charts that we looked at, we took a smaller population. Notice, peds is a smaller little group, which we're not surprised about. We don't see that many peds in the first place, right? But we see about 6% peds, but the refusals is almost double than that. Which, again, I'm not surprised. These aren't sick kids, right? A lot of times they call us, and it's like, go to your pediatrician. So here is the breakout of the clinical conditions that we're seeing. So everything from trauma, motor vehicle collision, syncope, falls, chest pain. So these first 5, super high risk, right? We know bad outcomes happening with those. And so this is why it kind of pushed us down towards looking at this a little closer, because we're like, hey, these are common presentations of high scary things, particularly syncope. Syncope is one of those hard things that even in the emergency department, half the time we just admit these people because we have no clue what's going on and the risk is so high and people's outcomes are pretty bad. Now we do have some rules which help guide us with syncope, which we haven't applied in the EMS sector. And so it's something that we're in the process of discussing. So what we found is we, first of all, found that we had lots of refusals, but then what we did is we took those documented refusals and we looked at the charts and said, does this individual have a condition based on the documentation where they should not have refused? So was their condition so emergent that they probably shouldn't have refused? So we broke it up into no emergent condition, a likely not an emergent condition, equivocal, it's unclear if they had an emergent condition or not, likely emergent, or yeah, this guy is clearly emergent, the 70-year-old who had a fall and hit their head, or a trauma patient at 65 miles an hour who seemed a little out of it, probably shouldn't have refused. And now you can see the breakdown, that the likely emergent was higher than you would have expected, but people were still being able to actually do the refusals and being able to be signed off. And so, but the most interesting thing is when we took this group and we broke it down to the 4 key aspects of capacity, that's what was really shocking. So let's look at that. So these are the 4 key aspects of capacity, not the parts that we checkbox on our form, but the things that we truly document. So what this means is we're leveraging a lot of our checkboxes and signatures rather than a documentation of a true refusal, okay? And so you can see that we definitely do a great job talking about what they're able to communicate. Almost 90% of the time we're really describing well that they're communicating well. But when it comes to these other pieces of geriatric capacity, which again is not something which we've ever applied in EMS, and we've never asked anyone to apply this in EMS, okay? We have not asked anyone to document any of this stuff ever, right? But recall, applying and appreciating the condition to themselves, as well as saying their risks and benefits, aren't things that we've ever documented. And so when it comes to the concept of the critical things for capacity for what would be a high-risk patient population, I think in general EMS doesn't do it. And so this becomes an important concept because then it begs the question, are we actually taking good capacity assessments? So this is, of course, retrospective, and all these kind of things have lots of limitations. We're saying these are elements of capacity, but again, we're looking at clear documentation rather than check boxes. So some of these things are inferred, and it's just part and parcel of the craziness of looking at documentation. But it does give us something to think about. So in the end, when we think about this, we know that rarely all 4 capacity of something which is systematically and validatedly put together for geriatrics is not really brought together in the pre-hospital space. We are doing the standard of care when it comes to it. The question is, should we be stepping it up? And so that's a lot of the questions that I'm trying to push us towards asking. And so this is one of the areas I think is important for us to think about. So future plans, what should we be thinking about? Well, let's be honest, you should expect some sort of intervention. I do think that this would be something interesting for us to look at a little more closely, and an intervention where we actually start identifying things that we need to document when it comes specifically to these refusals will probably be better for patient care, as well as identifying to us the high-risk patients that we probably should not be taking refusals from. So with that being said, I think the biggest thing I wanted to bring up here is the hard work that the team did when it came to putting this whole story together. The other aspect is that when it comes to pre-hospital care in general, not specifically us, but pre-hospital care, we have a long way to go when it comes to understanding if we have systematic rules to define how we take care of our patients. And I think we all know that. We're missing a lot of the picture of data and a lot of the picture of what we should do and what's literature supported. And refusals is just one more of those areas. And we talk about it a lot, we argue about it a lot, and we argue about documentation, but we don't really have a systematic way of looking at this. And so it's nice to see that we're kind of going down the pathway to actually piece this out a little bit. With that being said, open to questions. More than anything else, this is some great work that our team over here has done. It's great to see that it gotten some national exposure. The way this was accepted at the national meeting, we had about 15 or 20 people who came to the poster for the presentation. So the presentation was really well accepted. Image Trend as well as ESO both came to us talking to us about developing like a check sheet for them based off our research, recognizing that we'll probably publish this and people will ask about it. So Image Trend wanted to be ready for it if it came down. And it will. So we're writing it, we're finishing up. And actually, instead of just looking at the 50, we went and looked at every single chart for that year. And now that we've gone through every single chart, it still looks a little consistent. Our documentation still is unbelievably high, but the other characteristics of geriatric capacity weren't assessed, which I'm not surprised. This was never an expectation. And so it's a good signpost for us to really start thinking about this. So this summer, what our leadership team from the medical director side is, we're going to be thinking about how to put together an intervention which is not labor intensive. So what I'd like to have is something that would be like a box which pops up where you just have to enter in a sentence, essentially, just describing what it is. So very specific and directed to what we need, and that's it. And that way we can improve those concepts. I'm not, Jeff, I am totally missing the point right now. I see your question. Well, what are you referring to, Jeff?
What we spoke to last time in the TBI lecture.
About... Oh, yeah. Oh, balls, not gals. Okay, I get it now. Sorry. Sorry.
Autocorrect turned it to gals.
Nice. So yes, elderly falls is a classic example of challenges for capacity, right? So in elderly falls, one of the common things is what we see with TBI when they've done the systematic evaluations of elderly patients who have fallen. There is no systematic rule that you can use to safely say someone does not have a subdural, because the propensity of a subdural in someone who is over 70 is so high after a fall. And that's specifically in people who have falls without mechanism of hitting their head. So just the acceleration, deceleration injury is enough to tear those bridging veins and cause you to have a subdural. And none of our rules when it comes to CT head scanning rules have ever been shown to be appropriate enough. So the emergency medicine rule right now, all across across emergency medicine, is scan these old people, right? And we're taking the refusals. And so it's one of those things where there's a disjoint, right? And we're gonna have to think that through a little bit and try to figure out what the best way to manage that disjoint is. Good point, Jeff, real good point. I saw another question in there, which I'll address at the end. Any other questions about this refusal stuff? More than anything else, I'm just really proud of our team.
I got two of them, actually.
Please.
Since we've kind of moved away from what we're calling competence, because it's a legal term,
nice.
and moving to capacity, how do these two things line up if we were to get called to court?
Great question. Awesome question. They don't. That's the problem, right? So competency is very much a legal term, which are often defined by a psychiatrist, right? And so they're doing a full mini mental status and all that kind of stuff, looking not only at their ability, but it's also cognition and all those different pieces. So like if we have somebody with even mild dementia, they may actually fail competency yet pass capacity assessments.
Okay.
As we are now. Okay. Now, the four things that we have as our critical aspects of capacity do take in cognitive competence. So the four characteristics that we're looking at would bring us closer to being aligned, whereas currently we are not aligned. That's a great point, Sean. And actually, you expressed it better than I would have. That was very well.
Okay, second thing is, since we're on like the falls and stuff like that and the propensity for the subdurals, right now, especially in the geriatric community with COVID, they're literally afraid to go to the ER. And with, their capacity, would be fine. They know where they're at. They know what's going on. They remember what they had for lunch, the whole bit. They're going to pass, but we know they need to go. At what point do we say, either just call it off and say, hope you don't die, or say, hey, you really push the issue?
No, and I like exactly what you're saying, because I think, frankly, this is my frank opinion, there is definitely a point where we just need to say, sorry, I hope you don't die, right? But the other aspect of that is we may have to take a little responsibility for callbacks, right? Which traditionally, I think a lot of us in our heart actually do it, and we'll like say, yeah, I want to just check on that family. And I think a lot of us actually innately will do some of that. But we may want to think about how we handle some of those pieces, about how we follow up with those specific families. And some of the data out of Upper Arlington with their lift assist and fall prevention paradigm, and I'm actually part of those research studies, are really showing us that callback and follow-up by EMS concerning falls is really important to prevent the revisits and being taken to the hospital with a subdural. And so I think all of these things kind of come together, but I don't think we've ever really looked at it together. Does that make sense? And so I think you're pointing out the exact challenges that the research will probably address.
Cool. John, I want to, what Dr. Panchal said, I think you push the issue, and then like he said, there's a point where, they're just simply not going to go, and then you have to accept that. I think what we want to avoid is the scenario where you show up, not you, I'm just saying you in general.
Yeah.
Show up, there's an elderly fall, you lift them up. Do you want to go to the hospital? No, I think I'm fine. Okay, you sure? Yeah, I think I'm fine. Okay, we'll sign right here. You can always call us back if you need us. We want to avoid that conversation and put more emphasis on, all right, ma'am or sir, we would like to take you to the hospital because of this, instead of starting off with do you want to go? I'd like to take you because of this, and then be just a little bit more convincing with it. Now, obviously, I'm not there during every single one of these. I've just, I was on the ambulance for quite a while too, saw a lot of these conversations occur, and I know that typically EMS doesn't do the best job of trying to convince somebody to go to the hospital who appears to be perfectly fine. So sure. That's what, from my point, I think that's what Dr. Panchal is saying, is just more emphasis on the attempt.
Gotcha.
No, and I completely agree. I think that's one of the challenges that we're going to have to face, is the fact that there are these elderly people who have these falls and they don't understand what their risk is really. They're not medically informed enough, like we are, to know that their risk of a subdural is 15%. They don't know that. But medical legally, we're held to a standard of missed MI of less than 1%. That's not in the world of reality, right? That's not the world of reality. But I think with our refusals, we're gonna have to be a little more aggressive about defining that. And so hopefully, as we start putting this this checklist that I want to put together, this thing that pops up to help us kind of define it, I really want to make that the least amount of work, but really there'll be signposts to remind us of the things that we should worry about.
Cool.
Hey, Dr. Panchal.
Yes.
I was just going to say, it's on a different subject to a certain extent, but I know that we've had several falls that were supposedly lift assists and people did not want to go. But one was where the person had severe back injury. They ended up going to Grant, and we had another one that had complications. And the way that we were able to do that, not that I was crazy about doing that in the first place, is taking vitals and stuff like that on a lift assist. But that's where I've caught that. They were abnormal vitals. We were able to convince them to go, and that's what we found. So,
no, that's a great technique, because all these old people will be tachycardic, every single one. And especially when they're tachycardic to like 120, which you could say, this is double normal. You shouldn't be here. It makes it a little easier. That's a great approach to that.
I think if you keep in mind, it's informed refusal rather than informed consent or informed ability to go to the hospital. Try to make that point that we would rather you go to the hospital, but we want to make sure that you are completely informed with all parameters and all possibilities that you may end up dying from this.
Yeah.
You may have to use words such as, do you realize this may kill you today? So think of it from the framework of an informed refusal rather than an informed consent.
And one of the other things that people have leveraged lately is actually calling me, which has actually worked out pretty well in a couple of cases where, especially like we had this guy with a syncope on a tractor, and he didn't want to go to the hospital. I'm like, that's high risk. Like having 2 syncopal episodes on a tractor just does not sound good. And they called me to help them, and this guy would not go. There's no way this guy would have ever gone. And so we had to take the refusal, but they sent me his 12 lead, things like that. I talked about his risk with him and things like that. And so it makes a difference, and medical legally, definitely more protected, but also having a medical, there is a couple of studies which have shown engaging a medical director in the refusal discussion does actually get people to go to the hospital. So feel free to call me. I'm around. I'm here. Last thing I want to comment on was a question on nasal intubation. Yeah, that's probably gone. At this point, we're probably done with it. Our success rates are pretty bad, and people aren't using it, and it's a rarely used skill, and we don't train heavily on it, and a lot of that has to do with the fact that we have better choices now, especially with the use of CPAP and things like that. Now, through the COVID period, obviously CPAP and our nebulized treatments are a little tabled, but definitely go RSI, and we will continue pushing RSI and King Vision and things like that. So that's probably where we're going to go.
So I have a question. When it comes to the falls, since we're wanting to push the elderly over the age of 70 to go to the hospital, is that something that we should change our response in general? Because a lot of those go out as a lift assist, which we run non-emergency status to. So if we're going to try to encourage these people to go to the hospital, then I feel that we need to start from the beginning approach, and they should be going out as a fall and not a lift assist.
I love what you're saying, and that is so smart. And it's a big change, right? Because that is a cultural change not only for us, but that would also be a cultural change for the whole county, because that would come from the level of Delcom, right? And since I am the director of Delcom, this is something that I did discuss last Wednesday. So it actually has come up. I think one of the things we're going to wait for, specifically for that change, would be the universal protocol. We are 3/4 of the way through going through the whole protocol to update it. And so if we can do this all as part of the overall universal protocol, it may be 6 months to a year delayed, but if we get everyone on board from the EMS and clinical side, such that the change on the dispatch side is not something looked at as ridiculous, then I think this will be a lot smoother and we'll have better outcomes rather than a lot of fights. And so that was kind of the approach I'm taking in for right now. I recognize that I'm not normally a patient person, but my patience has been tested most recently. So yes, I think the way you're looking at it is the right way to look at it. I'm just playing with other games right now.
All right, I have a question.
Far away.
Too. So we're talking about lift assists, but are we talking about falls with injuries, or are we talking about lift assists? Because You know, we have several patients over here who we frequently go on where it's, I was moving from my bedside commode back to my wheelchair and I slid down to the floor. And that's a lift assist. I mean, that's just, I just need help standing up. I can't stand up. Versus I was walking, I tripped on the throw rug and I fell and I smacked my head on the floor. You know, that might get dispatched as a lift assist, but that's more of a fall with injury. So are we talking about kind of redoing our differential run? Is it a fall with injury or is it just a simple true lift assist?
Yeah, I like what you said. We are not changing the nature code of the dispatch, which I think is what you're going after. Because I think a lift assist and a fall are distinctly different based off nature code when it comes to the dispatch concept, right? So a lift assist would be someone exactly what you described at a nursing home or at their own private home where they're having a hard time getting up, and normally they walk around with a walker or something like that, and that would be from standing, right? The concern is that it's a little bit of both, but I think it may be a better change on the EMS side, where when you come on a lift assist, similar to what Jeff was saying earlier, we don't think of it only as a lift assist. We think of it as a rule out fall, right? So similar to what you just described is that, hey, I recognize and I get a better story when I'm on the scene. This lift assist is now a rule out fall. Wait, it is actually a fall. And I need to think about this more closely. And I think that's what our direction for the capacity assessment will lead us towards, because again, that's more thinking of the refusal side. So I have not at this point thought of totally upending how we think of fall and lift assist. That's something that we will talk about in the future. And Upper Arlington's actually doing those studies right now to look at that whole question. So I don't think we need to reinvent something while they're doing the real studies right now looking at that question.
I understand the type of scenario you're talking about, and I do not believe that that falls in the realm of what Dr. Panchal and I are talking about. You're referring to somebody who truly is a lift assist. They just slid down or they can't get up. What Dr. Panchal and myself are referring to are deceleration injuries. It doesn't have to be somebody who just hit their head. It could also be an elderly person that fell, didn't hit their head, but there's still high risk for a deceleration injury to their head, even though they didn't hit it. What you're referring to sounds like a true lift assist, where the person simply needs assistance in being lifted from one place to the other, or maybe they slid down a little bit because whatever their medical condition is causing them to not be able to carry themselves from the commode to the bed. That is a lift assist. I don't think anybody's advocating that you show up and say, no, you need to go, there's a risk here. What we are advocating is if that person was to have then fallen while trying to get from the commode to the bed and there's a risk for a deceleration injury to the brain, that you do show up and advocate on behalf of the patient and say, I think you should go and be examined and checked. There is a risk here. Does that answer that question?
That answers that question because, to be honest, I mean, most lift assists, and I'm talking about the lift assists where the example I gave of we're just helping someone back up. There's not a risk of injury. We're not talking, we don't typically get a sign off on those. We just, hey, there you go, help you out, like have a good day, call us back if you need us. But if we go on this lift assist and we find out, well, yeah, they need help off the floor because they just fell and they hit their head or any injury, then we typically do a sign off because it's like, well, maybe you ought to get that checked out. No, I don't want to go. Okay, here, sign here, says we were here and offered you a ride. You don't want to go. So I just want to make sure we weren't universalizing everything into one category.
No, we can't too. It's a little too, I agree. You can't universalize it. It's just too hard. But I will have to say, I think over time, we will probably be looking a little differently at the concept of lift assist. Maybe not on our frontline side, but maybe on the back end. Because what we're seeing in some of the data on lift assist from our research study is that those individuals who have lift assists essentially will call for EMS care for transport pretty soon after their lift assist, because the other part of the puzzle is never getting closed. And so then they end up being a high-risk person, and they end up actually falling, ending up in the ER, and that increases their morbidity and mortality. But that's a different question in a different direction. Great discussion, guys. Well, again, you know me, I like to keep this down to 20 or 30 minutes. I'm happy about the discussion, but I'm going to try to wrap us up. Any last thoughts or last words before we wrap up?
I'd like to make one comment about the nasal intubations. We really aren't teaching that in the medic schools anymore for the last 5 or 10 years, just because it's such a procedure that has too many risks, too many pneumococcal infections and things like that. And so I really didn't teach it much in the last 4 or 5 classes, other than, well, here's how to do it, but you're not doing it much with CPAP and BiPAP out there.
Yeah. Yeah. I think that's where the field's going anyway.
I agree.
Cool. Great, guys. Thank you all again for joining. We will send this out as a recording for everybody because I think it's just a great discussion and it's nice to get this information out. Go out there, be safe, make sure you use your PPE, and thanks again for joining on. I'll catch you all later.
Thank you.
See you guys.